Hi everyone, this is Dr. Disney, physical therapist, here to review how to perform a neurovascular screen. A neurovascular screen is an important part of a physical therapy examination. This video will review how to examine lower motor neurons as part of your neurovascular screen. We're going to look at dermatomes, myotomes, and deep tendon reflexes. We'll go over each one of these individually in the neurovascular screen. Let's start with dermatomes. A dermatome is a specific sensory pattern that correlates with the spinal nerve root. We will check that all spinal nerve roots are intact by assessing the ability of the patient to feel light touch. Here is an image of all the dermatomes in the body from C3 to S5. C3 is the lateral side of the neck. C4 is around the shoulder area, that lateral upper brachial area. C5 is the lower lateral forearm. C6 is most specific at the thumb and pointer finger. C7 is most specific at the middle finger. C8 is noted along the ulnar border of the pinky finger. T1 is on the medial forearm, and T2 is on the medial upper arm. T3 through T12 has segmental innervation throughout the torso. And then we come down to the lower extremity at L1 and L2. That you'll feel or pick up around the anterior medial thigh. L3 is most specific along the medial side of the knee. L4 can be found on that medial lower leg. L5 is found on the lower lateral leg. S1 is along that fifth toe or the lateral border of the pinky toe. S2 can be found on the posterior lower leg. If a patient has decreased or absent sensation in a particular area, you need to document this along with the location. There may be a nerve-related injury. A dermatome assessment is very quick. The patient is usually seated at the end of a chair or a table with the arms out to the side. Watch the following clip for an example. So we're going to do a dermatome assessment. I'm just going to touch on both sides of your body at the same time. Let me know if you can feel the sensation and if it feels the same on both sides, okay? I'm going to start with your arms. Can you just hold your arms out like this? Good. Does this feel the same on both sides?
Yes.
Good. So we're first starting with the C4 dermatome. Does this feel the same on both sides?
Yes.
Good. That's the C5. What about here?
Yes.
Or here?
Yes.
Good. Both of those are checking the C6 dermatome. What about here?
Yes.
Good. Here?
Yes.
Okay. What about here?
Yes.
Good. So we did C7, C8, and now T1. Last but not least, what about here?
Yes.
Good, and that was T2. Okay, thank you. So we did the upper body, now we're gonna do the lower body. Can you roll your shorts up just a little bit? Perfect. So I'm gonna be touching on your lower legs. And again, let me know if it feels the same on both sides, and if you can feel the sensation. So here we're looking, does this feel the same on both sides?
Yes.
Good, so we're looking at L1 and L2. Here, does this feel the same?
Yes.
Good, more of that L3 dermatome. What about here?
Yes.
Good, is the L4. What about here?
Yes.
Good, is L5. What about here?
Yes.
Good, and that's the S1 dermatome. That is the full body dermatome assessment. I'll talk a little bit later about why I excluded S2 through S5 and when I would include C1 through C3. You may have noted that I excluded the S3 through S5 dermatome. In the previous picture, you could see that this is a very personal and private area that we are likely not going to be palpating in a typical ortho exam. For that reason, it is appropriate to ask your patient if they have had any pain or change in sensation in this area. The easiest way I have found to ask this difficult question is by asking if they've had any pain or change in sensation in an area that may touch a bicycle seat. Most people understand this reference and get the idea. I'll explain in a later video why this information may be necessary. Also, I excluded the C1 and C2 dermatomes. These dermatomes are highly correlated with headaches. The C1 dermatome creates a mohawk distribution down the back of the head, and the C2 dermatome can refer to the ear area. You can palpate this area similar to how we did the other dermatome assessments. Now that your dermatome assessment is complete, we will move on to a myotome assessment. Myotome findings will typically correlate with dermatome findings. Myotomes assess muscle control in prime mover muscles in the body. These correlate with spinal nerve roots that innervate these major muscle groups. If you find weakness here in this assessment, there may be a spinal nerve root involved. Make sure to document the corresponding spinal level and the amount of weakness found. C1 through S2 myotomes can be assessed. Here is an example of a myotome assessment. So we're going to move on to our myotome assessment. How you grade your myotomes is just like you would grade any kind of strength assessment. So you could grade it on a 0 to 5 scale like you would with your manual muscle test per Kendall, where 5 out of 5 is the strongest, 3 out of 5 is able to hold against gravity, and 0 out of 5 is absent. You could also grade it on a qualitative scale as far as normal, good, fair, poor, or absent. Just stay consistent whatever you decide to do. So I'm going to do a quick myotome assessment. I'm just going to be looking at the strength throughout your body. I'm going to have you sit up really tall for me. Good, and I'm going to start with your neck. So I'm going to give you a little bit of resistance around your neck. Can you just nod your head forward and hold there, don't let me move you. Good. And then what about, can you bend backwards? Good. Hold there. Don't let me move you. Good. So we're just checking C1 and C2 myotomes here. Can you side bend to one side? Good. Hold there. Don't let me move you. Good. And then side bend to the other side. Good. Hold there. Excellent. So that would be the C3 myotome. How about shrugging your shoulders? Can you do that? Good. Hold there. Don't let me move you. Good, is C4. How about coming up out to the side, shoulder abduction. Hold there, don't let me move you. Good, so that was C5. Go ahead and bend your elbows by your side. We're just gonna check C6 myotome. Hold there, don't let me move you. Good, and we can also check C6 with wrist extension. Can you do this motion? Good, hold there, don't let me move you. Good, and same thing on this side. And this is all pretty normal and even, 5 out of 5 strength so far. Let's do C7. Come back to this position. Yeah. Hold there, don't let me move you. Good, as we're checking elbow extension. And then how about flexing your wrists for me? Good, wrist down all the way. Hold there, don't let me move you. Hold and hold, be strong. Good. We're gonna check C8 myotome with thumbs up. Good, don't let me push your thumbs down. Hold, hold, hold. Good. And then T1, open up your fingers all the way. I'm gonna weave my fingers in between yours, and I want you to squeeze as tight as you can. Squeeze, 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 squeeze. Good. Upper body so far is all 5 out of 5 strength. Okay, we're gonna move on to the lower body. So I'm gonna have you take this knee. Can you take this leg and meet it to my hand? Hold there, don't let me move you. Good. And same thing on this side. Hold here, don't let me move you. Good. So we're checking the L1 and L2 myotome. We're going to move on and check L3 with knee extension. Go ahead and kick out there. Hold, 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 hold. Good. And again on this side. Hold, 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 hold. Good. We'll move on to L4, ankle dorsiflexion. Go ahead and pull both of your ankles up. Good. Hold that there. Don't let me move you. Good. And same thing on this side. Hold. Perfect. Now we're going to check great toe extension with the L5 myotome. Pull your big toes up as high as you can, and don't let me push them down. Hold, hold, hold. Good. And lastly, we've got 2 more actually. We've got the S1 myotome, which is plantar flexion. Go ahead and push down like you're pushing on a gas pedal. Good. And same thing on this side. Hold, hold, hold. Good. And then the S2 myotome, go ahead and bend your leg underneath the table. Hold, activating knee flexion and hamstrings. Same thing on this side. Hold here. Perfect. And he's also a 5 out of 5, normal strength for the lower body myotome assessment. Fabulous.
5 out of 5.
Now that we have completed the myotome assessment and dermatome assessment, we will move on to check the deep tendon reflexes. If a lower motor neuron or spinal nerve root is involved, expect to see diminished reflexes. If an upper motor neuron issue is present, the patient will present with exaggerated reflexes or hyperreflexia. You can assess these reflexes on almost any tendon. We will focus on these common deep tendon reflexes: the C5-6 biceps reflex, the C6 brachioradialis reflex, the C7 triceps reflex, the L4 patella reflex, and the S1 Achilles reflex. Here is an example of a deep tendon reflex assessment. This patient demonstrates normal reflexes, which are documented as a 2+. Diminished reflexes are documented as hyporeflexive, or 1+ or 0, indicating absent reflexes. Hyperreflexia can be documented as 3+ or 4+ with clonus. So now we're moving on to the deep tendon reflex part of your examination. Here you're going to need your reflex hammer, and I'll explain when to use the flat end of your reflex hammer and when to use the pointed edge. So we'll start with the upper body reflexes with the C5-6 reflex, which is the biceps reflex. So how you're going to do that, you're going to have your patient sit up really tall, and you're going to want to support their arm bent at about 70 to 90 degrees of elbow flexion. You're going to palpate the distal biceps tendon with your thumb, and you're going to make sure that that arm is relaxed and the patient's relaxed. Then you're going to use the pointy part of your reflex hammer, and you're going to strike right over your thumbnail. What you should see is a little bit of elbow flexion, as that's the function of the biceps. Good. So we're seeing a normal response here. This would be a 2+ normal reflex response. Then we can move down to the brachioradialis reflex. Here I'm going to use the flat end of my reflex hammer, and I'm going to tap just proximal to the radial styloid, near where the brachioradialis attaches. We should see a little bit of elbow flexion with this, as that is the function of the brachioradialis. And we're getting a normal amount of elbow flexion, so this would be a normal 2+ response. We'll move over here to C7 reflex, which is elbow extension. Here we're going to be palpating the distal triceps tendon and striking right on the tendon. You can decide whether you prefer to use the pointed end or the flat end. I prefer to use the flat end. So we'll make sure their arm is supported. What we want to see with this is just a little bit of elbow extension here, and we'll also see the triceps contract. So we're seeing a normal 2+ response with this. We see that triceps contract and the elbow starts to extend. We would repeat this same process on the opposite side. I'm also going to move down just to treat his left side, assessing now the L4 reflex at the knee. This would be the patellar reflex. We can palpate the patellar tendon here. We're going to use the flat part of our reflex hammer to strike right on the patellar tendon. We want to see a little bit of knee extension with this reflex. Good. So that would be, again, a normal 2+ reflex response. We're moving down to the Achilles. Here you're going to passively, make sure it's passive, passively dorsiflex your patient's ankle, and that's going to put some tension on the Achilles. Again, we'll use the flat part of our reflex hammer to strike the back of the Achilles. So just go ahead and relax your ankle. I'm going to move it up for you. Good. What we want to see is a little bit of plantar flexion, and we'll also see some contraction of that gastrocsoleus complex. So again, relax your ankle for me. I can tell he's not relaxed because I can see his anterior tibialis popping on. So try to relax your ankle. There we go. Try to relax for me right there. And we can see just a little bit of plantar flexion of the ankle and a little bit of contraction of the gastroc, indicating a normal 2+ reflex response. That concludes our simple neurovascular screen for lower motor neurons. However, there are many other examinations which could be performed in this screen. Look out for more information, including upper motor neuron assessments, in later weeks.